So I'd like to introduce this next session, Symptom Management, from strollers to walkers and everything in between. It's being presented by Jody Krastic and Patrick Coyne. Jody Krastic has extensive experience in pediatrics, perinatal, and palliative care. She is the co-founder of the Children's Institute for Palliative Care, which is the educational arm of the Children's Pain and Palliative Services and the first federally funded program for pediatric palliative care. She currently works as the Pain and Palliative Care Coordinator at the Children's Hospitals and Clinics of Minnesota. Jody has published and presented nationally and internationally on the issues of pediatric palliative care. She is also a member of the HPNA Board of Directors. Patrick Coyne is the clinical nurse specialist for palliative care and pain management at the Virginia Commonwealth University Healthcare System in Richmond. He is the clinical director at the Thomas Palliative Care Program, which is one of 6 Robert Wood Johnson National Palliative Leadership Sites. Patrick has worked diligently to improve palliative care and pain management nationally and internationally. Thank you to our speakers.
Well, you're looking at 2 risk takers up here right now, because when we plan this program, everything about this program actually relies on you. So while we may be the presenters, we're actually more moderators, because we wanted this to be a dialogue about symptom management and the challenges of it. So we're going to bring some cases up, give some ideas, some examples, but we really need to hear from you, because we want to talk about things that impact your practice, ideas of things you're doing that may be worth sharing, and really a way so that everyone walks out of the room and kind of says, I never heard about that, or we should try that, or they're absolutely insane. Pretty much?
Yeah, we just felt like there was so much wealth of knowledge in the room, and practices are so different from the left and right coast, and we want to be able to share it all together. So we're looking forward to presenting with you.
And I think that's the best way to say it. We're presenting with you. So our objectives are to identify approaches for symptom management and discuss really common therapies, but I think we're all open to thinking outside of the box, because that's really what palliative care often is thinking outside of the box.
And as our title suggests, we're looking across the lifespan.
So that would be little kids and old people.
And old people. Just like this picture here, some of you may see a young woman, and some of you might see an old woman. And if you look at it different ways, you'll perhaps see both.
You know, that helps me, because I keep seeing the young woman, and I thought it was supposed to be a cat. So I'm.
Why did you put a cat on this picture?
I don't understand that. Maybe it's good. I don't know. So we're going to talk about dyspnea, pain, anxiety, but really, we want you to understand that the forum today is yours. And so we have all these slides, and frankly, if we never get through them all, we'll be okay with that. And if we have other cases, we'll get to that too. So very, very inflexible. Flexible. Okay, so, well, I'm very inflexible.
We don't want to be inflexible.
We don't want to be inflexible. Thank you. So there are a lot of symptoms at end-stage cancer, and really, what have you seen lately? What are the symptoms that bother you the most when you go home at night? What's the symptoms that bother your patients and the families the most? So, I think that's part of why we're here today, is to talk about those. And so some of the symptoms that we're talking about today may not be the most problematic symptom for your patient or for really your colleagues or you. We have no intentions to talk about hiccups today that I'm aware of, but that may be the biggest problem you've had in the last week. And so, that may be something to talk about. How would you treat it? Maybe somebody's got a better plan than someone else, so we really want to go there. But what have you seen in your own practice with, I want to say standardization, but, I'm in a practice where we're in a large healthcare system, and I can see 20 residents treat the same symptom 15 different ways. Some follow the one before them. But I think it offers a challenge when you're trying to do, to improve care, figure out what worked and what didn't. How many of you, just for show of hands, how many of you have given several medications and you kind of look at each other and go, I wonder which one worked? Or was it all of them? Absolutely. So that's part of the challenges that we have too.
Exactly.
So what we're going to try to do is push that forward today. So what are the biggest problems of symptoms? And so we kind of went to the literature in dyspnea. So let's talk about dyspnea for a second. If you ask patients, what's the symptom that's most likely ignored by their healthcare provider? It's dyspnea. So the first thing to really tell us is what do you do in your practice to examine dyspnea? Are you measuring dyspnea? Patient report. Okay, so that's a really good point there, patient report. Patient report's really kind of critical because there are a lot of people out there, doctors and nurses, who are describing dyspnea by respiratory rate. Okay, surely respiratory rate's something you want to look at, but you can have someone breathing 18 times a minute and say they're exceedingly dyspneic. But if you didn't ask that question, you probably never knew. Well, there's some interesting scales out there for measuring dyspnea. So how many are using a scale to measure dyspnea? Maybe about a third or 25% of the audience. So for the rest of you, I guess my takeaway home message would be is you should be measuring dyspnea. Because if you don't ask, you don't know. And therefore, you need to figure out, are you doing better with the treatment of dyspnea? For those of you measuring dyspnea, what are you using? Edmonton Symptom Assessment Scale, okay.
0 to 10, I heard someone say.
0 to 10, great. Borg scale, okay. Anything else? Mild, moderate, severe, okay. That's still their own scale. So I guess what we're hearing is measuring dyspnea is a lot like measuring pain. You know, the Borg's a nice scale, but it's still 0 to 10. Okay, so let's talk about George. George has acute lymphocytic leukemia. His hemoglobin is 5.7 this AM. He complains of dyspnea as well as fatigue. His type and cross-match reveals numerous antibodies, so his blood transfusions is hours away, maybe longer. His O2 sats are 91% on 4 liters of nasal O2. Appears tired, slightly anxious. He's using no accessory muscles, and his breath sounds are clear. Pretty straightforward so far. So what other information do you need? Say it again. Respiratory rate, okay. Heart rate.
Is he able to talk in sentences, or are we talking phrases, or just single words?
Okay, so can he talk in full sentences? Can he carry on a conversation, or is it yes, 20 breaths, no, and at the end of the 4th question, he's kind of done? Okay, great points.
I heard someone say environment. I think that's a really good, important thing. What is environment like around him?
Absolutely, environment's going to be critical in terms of, is it a restful environment? Yes. Does he feel short of breath? Okay, great. Let's get right to the subjective thing. Lung sounds, great. Does he have added lung sounds, or are they diminished? Okay, very good. What's his position? You said position, not physician, right?
Good point.
Rest versus activity.
Okay, is it only with exertion, or is it at rest? So constant, or does he get it when he moves? Other things. Does he feel anxious, anxiety? Very good. Can he eat? Great question. Does he get too exhausted eating? That's an excellent assessment tool.
Is he in pain?
Is he in pain? So, okay. Can I add to that? Does it hurt to breathe? Okay. So could he have a fractured rib that may be adding to this? Absolutely. Great point, though. What else?
Acute or chronic onset?
Oh, very good. Did this come on quickly, or has it been going on a while? Big deal. So could he have thrown a PE? Pneumothorax? Or has this been something going on and on? Sure. Yeah.
Is this restricting his activity level?
So he can't do his activities of daily living or can't meet his goals because he's so restricted by the dyspnea. Really great. Yeah. Cough. Okay, so it's associated with a cough. So the cough would be, is it constant, nocturnal? Is it related to a new medication? There was someone way back there. Yep. When was his last blood transfusion? Interesting. Okay.
What does he think helps him?
What helps the dyspnea? Good. Yep, right next to you. Excellent. What else? Yeah. Great. Does he have edema? So is there some cardiovascular? Is he not, basically has no albumin and any fluids you give him aren't going to go where you want him? Really good question. Diaphoresis. Good. Underlying COPD. So is there a comorbidity? And I think that's something I said leukemia, but that doesn't mean he didn't smoke 30 packs. He had 30 pack years behind him, or a history of asthma, or, end-stage heart disease on top of it. Sure.
Hasn't had any meds.
Okay, could medications be impacting this? Absolutely. Really great thing. So the biggest takeout that I want you to think about is that nurses doing palliative care have got to have the best assessments of any nurses I know. Your assessment skills have to be job one, because people rely more on your assessment skills than they rely on labs, or they rely on a spiral CT. So I'm constantly reinforcing great assessment skills, because they've got to be critical. How many thought we would have probably 30 responses to dyspnea assessment? These are every one that came up here are very critical to think about for somebody in dyspnea, because it would have been really easy to focus on a hemoglobin of 5.7 and left everything else behind. So we do have it. Other things, any other thing you want to add? I've got one or two if you don't throw it in. Yes?
Did you ever put a fan by you? Did that help?
I'm an old man. Say it again.
You could ask the patient, did he ever have a fan in your
fan.
Did it help?
Fan. Okay, did fans help? Okay. Does he have ascites? Excellent. That's a big deal, yeah. What's his recovery like? After blood or after transfusions? Okay, so does the transfusion in the past help his dyspnea? So someone with leukemia has probably been through multiple transfusions. Really good question. Yeah.
I would balance on the O2 stat, because that depends on the hemoglobin. And so your stat number's not going to be accurate with the hemoglobin that low.
Okay, so her point is don't put a lot of energy on the O2 sats with such a low hemoglobin, because it's probably inaccurate. Really good point. Yeah. Any cerebral vascular issues? Oh, okay. Would a non-rebreather work better? It's a question. Huh? Fevers? Okay, who? Mentation. How is he thinking? He's got a low hemoglobin. He's fighting to breathe. Sure.
His sleep? Has he been sleeping?
Oh, has he been sleeping? Really? Could he be exhausted because of all of this, too? Adding to it. Excellent. Is he anxious?
History of falls, safety concerns.
Safety concerns. Okay, is this guy actually going to be safe to make it to the bathroom because of everything going on? Does he want to be intubated? Thank you for that. But honestly, you have to think about that too. So I'm glad it's up there. BiPAP, somebody else is going to say, so I'll save that one. Anything else? Yeah.
Reynolds.
History of Raynaud's. I wouldn't have thought of that. Interesting. Is he a Jehovah Witness? Okay. Good question. I think we're done here. I'm gonna move on unless there's another assessment piece we may have missed, because You guys are good. One thing that I didn't hear, and I'm just going to throw it out for my sake, does he have added heart sounds? So could he have an S3? Okay, could it be AFib? And I know somebody talked about heart rate, but could he be in a rhythm that actually is making him dysmic? So things to think about. Okay, and we haven't talked about other labs that may come into play. So what do you do now? You got a guy who is kind of short of breath, not doing all that well. So think about, he's got oxygen on, and he's dysmic. Blood's not coming very quickly. What do you want to do? So someone just yelled out, morphine and Ativan. Is that all we're going to do? Morphine, Ativan?
And a fan.
A fan! Morphine, Ativan, and a fan. We can make this into a mnemonic by the time we're done. What would you do where you are? Call respiratory. So you do want to intubate them. Okay. Okay, so let's think about where you are. So I know those of you who are doing hospice, the answers may be very different than those of you who are in an institution and setting. So we have to think this through. So in your environment, the answer may be very different. So when we think about potential treatments for dyspnea, actually the first thing before we throw out drugs, the first thing we really have to think about was the etiology. Okay, because the reason the patient could be dyspneic, are they fluid overloaded? So the right answer may be Lasix versus morphine. Doesn't mean you wouldn't use morphine, but I'm just saying another drug. What about if you've got a leukemic patient? What if he's short of breath because he has a pneumonia? Okay, so maybe the right treatment is actually an antibiotic, but then again, you're into your patient's illness trajectory. You know, because there are some patients in palliative care, we are going to aggressively treat a pneumonia because we think they have many weeks or months or longer to live. And there are those that may have hours to days, and we're not going to treat a pneumonia. So all of the answers today are always going to be based on where are people on their illness trajectory, and is it something worth treating? Does it offer benefit, or does it offer a burden? And I think as Jody, as I talked today, we're all part of the big takeaway you should always be thinking of. If you're going to do a test, you're going to do something with the results. So if somebody here said get an ABG, that means to me you're going to do something with the information other than go, oh. It means you may be thinking of intubation, you may be thinking of non-rebreather, but if, you know, so my favorite story with dyspnea, people have heard this before, but I'm in our medical respiratory ICU with a gentleman who I've known for many years who's got end-stage heart disease, and COPD, and thank you for blessing me. And he has been intubated twice in the last 4 months. Okay, he has an advanced directive DNR, never want to do this again. Meet him in the ER, he is working to breathe, nodding to questions. He is not going to talk to me. Ends up in the medical respiratory ICU. Has his advanced directives, the pulmonologists are really questioning this and really questioning whether he has capacity to answer, but the wife is supportive. Do not intubate. Okay, so that seems pretty clear. So I'm going up there and I'm seeing this man who I've known, and he's on a non-rebreather, getting with 6 liters of oxygen. So he's got 16 liters of oxygen going into his body right now. No way to physically give the guy any more oxygen. And I watch, and the intern goes in with the nurse, and they're drawing an ABG. So I'm like kind of sitting there going, what you doing? I'm a pretty quiet guy. So I went, what you doing? And they go, well, we're drawing an ABG. I said, I kind of guessed that. I've been around. Why are you doing it? He goes, and the answer was, because we do that every 6 hours. Okay, step back. What will you do with the information? And I just watched 3 people look at each other. You cannot physically give the man any more oxygen. You're not going to intubate him. Okay, so when you look at benefit, burden, and risk, there is no benefit to the ABG. What's the burden? ABGs hurt. I've got a guy who is already fighting to breathe, and I'm going to take away more blood. You can throw in there risk of infection. There was no benefit, there was only burden. But when we talk about interventions for this, we're always going to have to put these things on the table. So if this patient had a pneumonia, and we think we have a pneumonia, and I'm getting a chest x-ray, the benefit is if he has a pneumonia, maybe my plan is to treat it. So it's worth the burden of putting the patient through it, or a spiral CT or whatever we think. So we have a lot of potential treatments here. And it all is going to boil down to what you are treating. So morphine may be a quick answer, but maybe I'm looking at antibiotics. Maybe I'm looking at heparin if he had a PE. Because maybe that's where they are in the illness trajectory. Still treating the symptoms as we're going, but I may be looking at other things to treat as well. So let's talk about our guy with leukemia and make the assumption right now that he is very anemic, he is very scared. Okay, he could have a pneumonia. Leukemics get pneumonias. I may or may not treat him depending where he is on his illness trajectory. Do I think I can get this guy another month or two? And it's funny, we wrote this case up 4 months ago. I saw this guy in the clinic yesterday. This is him, the exact same guy. So I was like, wow, this is really scary. So what were the potential treatments? Well, first thing, who said morphine? First thing we thought of too. This guy is working really too hard to breathe. So first thing I have to do is why we're treating a symptom, we should be aggressively treating a symptom. The question is, do we need to find the cause of the symptom? So both can be done simultaneously, and that's really where palliative care can be amazing. But the first thing was the morphine. In our case, we use fentanyl nebs too. But I also think of if there are other potential treatments. So medication interventions, let's talk about those. The data for dyspnea is the number one treatment for dyspnea, regardless of etiology, is opiates. In fact, the data's in there since the 1800s. There's really no better data for dyspnea. But that doesn't mean if it was COPD, I wouldn't be looking at a bronchodilator. Okay, that doesn't mean if it was fluid overload, I wouldn't be looking at Lasix. That wouldn't mean if it was another type of cancer, I wouldn't be looking at steroids to decrease tumor burden on an airway. So the right medication may be other medications as well. So once again, good assessment to figure out what is it you're after. So if I have a tracheal swelling from huge tumor progression, the steroids may actually do more than anything else I've offered here. So thinking those through. In those of you who work in the acute care setting, you see more and more fluid overload because when you get a palliative care consult, they've already given 12 liters of fluid and it wasn't working. So maybe Lasix is the way to go. Or if you're in the home hospice setting, they're still feeding the patient and the PEG tubes are going in and they still do 100 ml flushes. And maybe they needed more. So you really have to take that and look. So our medication interventions have to be there. The interesting thing with benzodiazepines in dyspnea is the literature does not agree. There are several studies that show that benzos may make dyspnea worse. There are other studies that show that benzos don't help dyspnea. There's some studies that show that they may be beneficial. My take of the literature is that if opiates haven't worked and there's an anxiety component, you should think about dyspneas. There is an article about to be published, and I can't reference it because I reviewed it, but that showed it seemed like the best benzo for dyspnea, at least in this one small study, seems to be Versed. And it beat out Ativan hands down. So keep your eyes open, but you may be hearing about that soon. Maybe more studies, but there are a lot of medication interventions that you have to look about. What other interventions would you use for dyspnea that we haven't talked about? So for a non-pharmacological intervention, position's critical. I agree. Any other medications I'm leaving behind? Yeah. I did say fentanyl nebs. I can tell you about fentanyl nebs. There was a study done in 2003. I think it's an older study. 2003. The lead author's last name was Coyne. If you looked in the Journal of Pain and Symptom Management, Coyne and fentanyl nebs, you'll find it. But essentially, we did a small, prospective, non-randomized study and used fentanyl nebulizers. And the reason I liked fentanyl and the reason we did it for the study is morphine nebulizers, by all the data, fail. And fentanyl is hypolipophilic, so it is allowed to spread, whereas morphine isn't. And the morphine nebulizer studies, I think there are 18 now that just don't show benefit, and there are 2 reported deaths. But the fentanyl, at least in the study, 79% of patients reported that it improved their breathing. We saw respiratory rates go down by an average of 4 breaths. 80% of patients said they felt better. 10% were uncertain. The other 10% really said, I don't know, maybe, maybe not. Last year in our facility, we gave 1,400 fentanyl nebs. We have yet to report a side effect. So it's something we do 25 mics and 2 of saline. Now, you could argue the saline is helping it, and I don't know the answer to that. We tried to do another randomized study in our site. In our site, it didn't work because the ER does fentanyl nebs. We couldn't get a clean patient with shortness of breath. So I encourage anyone who wants to do a study, take that study and do it somewhere else and blind it. But we can't do it. It's done too frequently. So 25 micrograms and 2 of saline is what we did in the study.
Does it have to be
Sugar-free.
sugar-free?
We're doing injectable fentanyl. Okay. Injectable fentanyl, by the way, injectable fentanyl is 27 cents a dose. So for those of you who are thinking we can't afford it. We actually do it in pediatric patients. Our pediatric palliative care program is trying to do it weight-based. I'll ask Jody to speak to this. In adolescents, we've pretty much gone to it. Our biometrics people's understanding about nebulizers is that the patient gets probably 8 micrograms in their lungs. They're probably swallowing 2 to 4 micrograms, and the rest is blown off. So if you think of 8 mics of fentanyl, that's less than 1 milligram of morphine. So we're talking very small doses, but with peds, they do it by weight if they're under a certain age, and I'd love to tell you the answer. I don't know the answer.
So we don't use a nebulized fentanyl, although the intranasal fentanyl is something that a lot of pediatric centers will use.
Okay. Yeah. All patients had cancer. In the publication, they asked us to exclude patients with AIDS, so we did. Okay. Yeah.
How frequently can you use that?
In our care sets, it's every 2 to 3 hours. In the study, we were saying every 4. But in theory, fentanyl is an hour drug, so like I said, you could look at using it more frequently. Many clinicians in our setting do, but like I said, this is something that needs more research. This pilot study needs more research. I just can't do it where I am. Having said that, it's used fairly frequently. Our local hospices have pretty much taken it over too. So I'm going to jump back to non-medications. So non-medications, first thing that was talked about was positioning. Other things that were talked about. Fans. When we did our assessment, do fans help? Ought to think about fans. I'm in a unit with one of the nicest places I can think of being, where we have ceiling fans in all the rooms. Now, it got the fire inspector really pissed off, and epidemiology didn't talk to me for a year, but it's something to think about if you're designing and to do that. But fans clearly have been shown to help. Cool, moist cloths have some data. Prayer clearly has data. Meditation has data. Pursed lip breathing. Number one reason for an occupational therapy consult is dyspnea. If you're not using them, I want my patients to get tired playing with grandkids, not tying shoes. So if you're not using your occupational therapist for this, you should be thinking about using your occupational therapist for this. Great intervention for them. So how to use them, depending where they are. Other things that aren't medication, new lasers to open up tumors, new stents to open up tumors. So these aren't medications, so I'm throwing them out there. Caffeinated beverages have been shown to increase pulmonary dilation of bronchioles, may help with breathing in some populations. So, few things out there. Yeah. So pleural catheters, actually, and also for ascites, a lot of those catheters that we're seeing more and more placement of. Now think about it, the first time placement is kind of a big deal, but rather than going in for serial taps, this may be a huge quality of life thing, and I think frankly we're just going to see more and more of them for the right patient. So, the rule of thumb by most pulmonologists and most people who put in the peritoneal ones is you've had to at least gone through 2 taps relatively close, and then everybody should think about it. But in some cancers, I think you have to think about this if the patient lives 40 miles away or 50 miles away and transportation is a huge burden and you anticipate it, it may be the right thing to do. So, but really good thing, and I think that's a great intervention we didn't talk about. One thing we did talk about was transfusions. You see I'm talking quicker because I want Jody to have time. It is transfusions, depending where they are on their illness trajectory, could be a great benefit, but it can also be a huge burden. So this guy with leukemia with multiple antibodies may spend an entire day in the hospital waiting for blood, or longer. So somewhere in this conversation, someone's got to be talking, there may be a day where transfusions are more of a burden than a benefit, and maybe you don't want to drive into the hospital. And maybe we can manage this at home. And that has to be part of the conversations. Unfortunately, the guy I saw yesterday, no one ever had that conversation. Yeah. Sure, calming effect, calming environment, you get the right person next to him. This may be the time you don't want the 12 grandkids running around the bed, but yeah, surely a calming environment. So thinking all these things through. But this is, once again, our job, think outside the box. Trying to do calming environment in the ER, not my best day. I'm throwing up here, in our system, we all live off algorithms. The nurses live off these. I live off these. And it's basically what I want you to take away from an algorithm, and these are available on the CAPC website. And if you ever did LNEC, they're in the LNEC book. I look at a subjective complaint of dyspnea. You can see in our setting we use fentanyl nebs, but you may not. If they have bronchospasms with wheezes, albuterol actually has better data. And if they have CHF, I'm looking at Lasix. So once again, back to great assessment, because one size will never fit all. So George develops fevers, delirium, agitation. What would be part of your assessment? Moving quicker. Too bad for George, I hear you. Infection, absolutely got to think infections. He's got fevers, and infection can cause severe agitation and delirium, as well as high fevers. Good point. If he has fevers, he also may be dehydrated. So rehydration, in fact, Eduardo de Bruera did a study in cancer patients, gave him a half a liter to a liter with patients who had less than 6 months to live, and found that he could get rid of delirium in almost 50% of patients. Small study, but interesting. So, maybe that beats someone spending the whole night there pushing haloarthorazine. But something to think about. Once again, back to your assessment, could they be dehydrated? So we do have to look at the fever. So what's the etiology? Cancer, could this be tumor fevers? So maybe they get these all the time, and it's kind of a red herring for you. Are they agitated? Are they of danger to themselves or others? So safe environment is going to be a big thing. Yeah. Could they be constipated? Sure. Constipation, urinary retention, unrelieved pain. The causes of delirium and agitation can be numerous. Some, a guy with end-stage prostate cancer whose bladder has 2 liters of fluid, they got good reasons to be agitated. Okay? Severe constipation. Are they hypoxic? That's causing them. So really, once again, really great physical assessment skills, because that's what's going to be driving you. And how would you treat these symptoms? So you've got someone, well, first of all, in end-stage disease, there's not much literature, guys, on treating fevers. There's one publication put out by a guy named Bart Bob, who I happen to know, in a textbook, but when he looked at how to treat fevers at end-stage disease, the literature wasn't a lot there. There are some arguing, and I think until we have more research, would agree, if someone has a week or less to live and they have fevers, there's really good argument for scheduled antipyretics. Because if you do it PRN, you're allowing the fever to reestablish itself. So scheduling it may make sense in that population, and that could be, Tylenol suppositories. If you're in an acute care setting, it may be scheduled Toradol if turning them is a problem, or we even have IV Tylenol now. But trying to find a way to do this. So figuring this out, but once again, remember, fevers may be more bothersome to the family than the patient. Feel him, he's burning up, this is terrible. So that you may be treating the family with this as well. The delirium, what can you fix? Is really the first question. So if there's something you could fix that would make the delirium go away, think about it. Remember, delirium in a dying patient is a family memory. And it is really something the family is going to remember. So if there's a way to fix it, you should fix it. Some patients, you're never going to fix it. Okay? Saying that right up front. But then we'll have to talk about other things. Yeah. Maybe they're hypercalcemic, so maybe you want to treat the calcium, maybe you don't. But if you want to treat the calcium, you may get rid of this and maybe by a month or two of good quality time, but depending where they are, yeah. Withdrawal, excellent. So are they in withdrawal from opiates, benzodiazepines, alcohol, or maybe some drugs we're not really aware of? Caffeine too, yeah.
Patrick, I work in the pediatric setting, and we actually find the opposite in terms of we found that everyone gets really anxious near the end of life and they escalate up those opioids, and we actually have kids who start having all sorts of delirium related to their opioids.
Excellent point. So in one study, I think this was Necessite, it's kind of old, but it's never been repeated, but in the last month of life, if you looked at a pie chart, it essentially cut it in threes, and it's not exactly a third, but basically there's a population of patients who are going to need 25% or more opiates. There's a population of patients that are going to need 25% or less, and there's a population that's going to be stable. And why would they need less? Well, their kidneys and liver aren't doing what they used to do, so the drugs just hang around a lot more. So sometimes with titration, we often think of going up, but sometimes we need to think about going down. And often I just don't see that scenario going both ways, but that's a really good point. So really the data, though, for delirium in terms of treating it, fix what you can fix, the drug of choice seems to be, without really any hesitation until something new comes out, is Haldol. Really, it has the strongest data, probably because it was a cheaper drug. Would Risperidol work any better? It may. I don't have the data to tell you that, or Geodone. It may, but I don't have the data. But with Haldol seems to be it. For those of you working in skilled nursing facilities, the challenge is chemical restraints. So if somebody, at least in most states that I've worked with, says, Haldol for the treatment of terminal delirium, basically the health department or whoever looks at them kind of says, that's an exception rule and lets it go. But that may be a challenge where you practice or where people go. So really, how do you do it is really trying to fix what you can and then look at what you can. Occasionally, this is following the previous speaker. You have to think about things like, how do we use more medications to make the patients more sedated? Fevers, once again, we're working off algorithms. It depends where they are in their illness trajectory. Agitation, as you can see in our setting, we're back to looking at Haldol, but we're also trying to figure out what's causing it. And at this point, I'm handing it over.
And Patrick, certainly jump in and add to your two penneth as we go along. So what do we know about symptoms at the end of life? And so I'll be looking at a little bit of some of the pediatric data, and you'll find that much of it is similar to your adult. And part of this is on purpose so that you guys can see that you do actually have a lot of skills to develop your pediatric basis. And certainly it takes more training and education, but want to encourage you to use what you have. So Joanne Wolf's study of 2000, she's done another one in 2008. But we look at the symptoms for children at the end of life, and none of those will surprise you. We see the same in adults. But let's look at how much so the green line is the frequency of the symptoms. The orange is the symptoms treated. And how successful was this treatment? And remember, this is in one of certainly the best hospitals in the country. So pain, 28, dyspnea, poor appetite, vomiting, and constipation. Certainly, we can do better for this for our children and for our adults. So just overview again of symptom management. Patrick talked a lot about evaluation, but to use evaluation, treat the underlying causes. But drug treatment should always be combined with supportive management, and we'll talk about that for each of the symptoms, and focusing on quality of life, which of course is what we do in palliative care. So let's look for a minute at Brittany. She's 4-year-old with widely metastatic cancer. She just had this fantastic trip to Disneyland. She was scared to go on the plane, so the family decided they would drive from Minnesota to Florida. It was a long drive. She gets home, she's short of breath, she's got a sore tummy, she's not eating, and she's tired. What do you think we might address first? How would we decide what we would address first? Breathing? Any other thoughts? What's that? She's tired. I didn't hear that. Thank you. Exactly. What's most important to her? What's bothering her the most? So let's say it's dyspnea. So when we look at dyspnea and look at it for Brittany and others, clearly we'll do the assessment. Often we use a 0 to 10 scale for kids. Sometimes, of course, it'll be the parents that answer that assessment scale. When we're working with parents, of course, you're very anxious if your child's having a hard time breathing, so you might assess it differently. We'd want to know what the normal breathing rate is. We have kids whose normal breathing rate, because of their, not cancer kids, but kids with neurological issues, normal breathing rate is 4 to 6. That's what Danny breathes all the time. So we want to know what their normal is. And if the child is not able to do a 0 to 10, or they don't want to, it's like, oh, I just hate it. You guys always ask me that 0 to 10. How about taking 10 cars? So if each of these cars are breathlessness, how much do you have? That same area works for pain. So again, use the assessment scale that works for the child or the person. And let's look at some of the underlying causes, of course, when feasible. And a lot of our kids have trouble with secretions. Are their secretions too thick? Are they just so copious that we need to get on top of the secretions? And Patrick alluded to fluid overload. Many of our children do have G-tubes. I think of a little boy who was very close to the end of his life. His body was shutting down. He was on continued GT feedings. And he was having a lot of secretions, and we talked to the family, and the body's shutting down. We really need to think about stopping the food or the medical nutrition, hydration, because naturally that's what bodies do when we shut down. And the parents just couldn't go there. It's like, oh, I can't not feed my child. Please, couldn't we try an IV? And sometimes, even though it's against what you would suggest, we need to go that way. And I said to the parents, I'm really worried that we're going to overload his lungs, we're going to third space, but they wanted to try it. And sure enough, the next day he was having more difficulty breathing, more edema. But for the parents, they needed to see that. They needed to make that decision. So certainly fluid overload we need to look at. So let's look at some non-pharm supportive therapy. One of the first things we want to do is calm the nurse. I got a call the other night about a medication error that was done in a group home setting, and the person was very dyspneic and anxious, and the staff got so anxious that they went to get the lorazepam, and they put lorazepam, and they ran and gave it to the patient, and then everything calmed down, and then they counted the lorazepam, and oh my gosh, we're 1 short. Oh dear, I think we put 2 in there instead of 1. And so the staff's anxiety, they had given her a double dose of lorazepam, which was what she got at night, so it was okay. But we want to make sure that we're calm. And when people are dyspneic, it's a very stressful situation, so we want to calm the nurse, maybe not with an injection like this suggests. So comfortable position for the child. We talked about this for adults, and when I first went from adult to pediatric, I took care of a baby with SMA, spinal muscular atrophy, and the baby was lying down flat. Now they're doing abdominal breathing, right? So what happens if you sit him up and he's doing abdominal breathing? What happens to his breathing? They have a harder time, right? So we want to find the position that works the best for the child. It may not be sitting up. Certainly, let's look at the environment, as people talked. Music, and again, when you think of music, think of the music that's helpful for the child. Some of our teenage music, the most relaxing music is dun, 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 dun. It's like, oh my God. But that's what they relax to. The temperature in the room, the humidity, certainly in Minnesota in the wintertime, it gets very dry. So we need to look at that. As you suggested, fan on the face, relaxation. And we do use aromatherapy. How many of you use aromatherapy? Okay, great. And how many of you use other complementary therapy, like maybe Reiki or healing touch or therapeutic touch? Okay, those can be really helpful. And again, it does take some education about, because some families will say, oh, that's against my religion. They think it has to do with religion, and so teaching them about that can be helpful. Other people have used their traditional medications in our Hmong and Somali populations. So pharmacology, when you look at these, nothing that's going to be surprising to you. I mentioned the intranasal fentanyl. One of the things that kids will say is that it burns, sometimes if you just kind of squirt it up the nose. When I've talked to people in Canuck Place, freestanding hospice in Canada, they say they use it all the time. Maria, I don't know if you guys use intranasal. Maria talks about sick kids in Toronto, how they use it all the time in the ED, and they use it now in palliative care too on the floors. And certainly we use titrated benzodiazepines, and we use all the methods there, the sublingual, oral, rectal. For some of our cultures, rectal medication is really not accepted. Our colleagues in Germany say that's how parents prefer. Oh, I'd much rather just pop something up their bottom than give it any other way. So just you want to check into whether culturally helpful that is. Oxygen, certainly we use, but we found if you look at some of the research studies, they found that in terminal dyspnea that the oxygen doesn't help as much as one would think, and so a lot of people are using compressed air. For our little babies, where the nasal cannula kind of, they're so tiny, those little nasal cannula go up their nose. So a lot of times we'll use blow-by oxygen. How effective that is debatable in research, but blow-by means just having an oxygen tubing by them.
How do you dose the fentanyl? I'm allowed to ask, right?
Yes, absolutely. So what we would use is 0.5 micrograms per kilogram per hour. So again, nausea and vomiting. We treat the cause, certainly look at anxiety, and remove sort of the common sense. We had a little girl who was 7 years old, and as she was diagnosed with cancer, her parents wanted to be really truthful with her, and so they had her sitting in all their conversations with the physicians. She was 7 years old, appropriately 7 years old, and she got so anxious because she had all this information that she couldn't take in. But the parents wanted, just to treat her like a little adult. And at the end of life, she had so much nausea and vomiting from every smell. You couldn't wear deodorant, you couldn't eat an orange, wash your hands and come in because she would smell that. So again, we want to realize that whatever is causing the nausea, or however we treat kids, we need to do it in an age-appropriate way, which wasn't done in this child's situation, and so she had a lot of anxiety. And so her anxiety came a lot from, or her nausea and vomiting came a lot from her anxiety. Any other thoughts on causes of nausea and vomiting? We have some, yes, thank you. Yeah, right. So it's just an air compressor that kind of blows it out the same. It's very like a concentrator, yes. And so it gives that airflow pressure, a little bit like the fan, that same pressure there. So there's different causes of nausea. Certainly, sometimes the opioids will be stopped quickly or changed to a different opioid in an inappropriate amount, so we want to take withdrawal into consideration too. So let's look at some non-drug interventions. How many of you use acupressure or those C-bands? Oh, okay. Not very many of you. Are you familiar with the C-bands? So you can buy them on the over-the-counter. But basically, it's the acupressure point. So if you just bend your wrist or take your 3 fingers and put it on your wrist there, there's a little site between those two tendons that you can push. It's very effective for nausea, and we actually use it quite a bit for kids in those C-bands. So it is a nice thing to keep in your bag of tricks. Distraction. How many of you enjoy telling kids stories? Some of you. Okay, so that's a really good thing to develop, is your storytelling ability. Actually, not only for kids, but for adults too, because adults get into those stories as well. And that distraction, because you know yourself, if you're feeling sick, and the more you think about it, the worse you feel. Aromatherapy. Any ideas about what's a good aromatherapy? Things that you've used? Yeah. Orange rinds, yeah, absolutely. Yeah, yeah. Anything else? Yeah. Frankincense. Okay, great. Lavender. Lavender is always a good standby. We had one person who was in actually cardiac surgery, had terrible nausea, and the only thing that helped her was peppermint oil. So just have these bags of tricks. And self-hypnosis. How many of you have done or know about self-hypnosis? Okay, a few of you. So I'm not talking about the tick, 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 and, you act like a chicken, and then, you jump off the stage or whatever. So self-hypnosis is really, particularly for kids, is really about going to your happy place, really focusing, getting the person to tell you about a wonderful place they would like to be and describe it in detail to help them kind of get out of that situation. It can be very effective. The pharmacology, again, some of these things none of you will be surprised at. Reglan, we have to use with care, of course, to the extrapyramidal side effects that are common with kids. We tend not to use that as much. We do use Haldol, but again, because of the extrapyramidal, we don't use it very much in our younger kids. It's kind of one of our choices of last resorts, except maybe for our teenagers. And we do use gels, not very much. There's not much literature that tells about the absorption of gels in children, but we have used them. And are you familiar with the BDR? Okay, so Benadryl, dexamethasone, Reglan gel, or there's also a rectal suppository, the bad drip. I would think some of you use the bad drip, Benadryl, Ativan, dexamethasone, and lorazepam, Benadryl, Haldol, and what's the M? Reglan, metoclopramide. Thank you.
If you look at the Journal of Pain and Symptom Management, I believe next month it will have an article about the creams and absorption.
Oh, great. That's great.
In the
Journal of Pain and Symptom Management, because those for kids are really helpful if we can start using them, because then they don't involve needles, they don't involve taking yucky things in your mouth. Please.
There was no absorption.
Oh, okay. The thing that's so interesting that there is no, but when you talk to, how many of you use gels across the country? A lot. And if you ask in a national conference, people use them all the time. And even morphine, which shouldn't work, right? Because bioavailability, it shouldn't work. People swear by it, and they use it all the time. So there's someone here who says, I know there's no literature, but we have had patients who did a 360 turnaround with the use of the gel. So maybe it's a placebo, but whatever works. Yeah. Yes, we use EMLA cream for any of our port accesses or anything like that, so that's a local anesthetic. Oh, yes, it's very helpful for EMLA. Yeah, because I haven't heard that. I've heard of people putting it here, or some just put a Tegaderm over the cream. I don't know how you use it. You use a Tegaderm over the cream, so you don't press it or rub it in there. So I don't know what to tell you, but I know I've heard many people say it works, and I've seen it work very effectively for our teenage patients. So sometimes we don't have all the answers. Certainly loss of appetite, and some of the kids feel like this little boy just, I don't feel like eating. So certainly we want to treat the underlying causes. may not be curable, but certainly oral thrush. We had one of our nurses who, again, I'm telling you all our dirty laundry here, but went out and said, oh, the baby's not eating, etc. She hadn't looked in the mouth, the baby had oral thrush. We want to make sure we do a good assessment. And looking at medical nutrition and hydration, are they getting too much in their G-tube to even be hungry? So again, let's look at non-farm. You guys are useful for small, frequent snacks. Whatever the child wants. I know our families often will say, oh, it's not very healthy to just have ice cream. When we're looking at end of life, whatever they want goes. Guilt and expectations. How many of you have fielded calls say, oh, my mother hasn't eaten for 3 weeks or 3 days, or right? You get all those calls all the time on call. She hasn't eaten. What are we going to do? We see the same thing with kids, and I think in some ways it's harder, because what do you do with babies when they're born? You change them and you feed them. And so when children are dying, it's really, really hard. And this guilt and expectations is there. I remember visiting a teenage boy, and I went in and Mom said, oh, I'm just so mad at him. He said he wanted a steak, and I went out and I got the best steak and I cooked it. And, he ate like one bite. I mean, he's not even trying. So there was a big conflict set up, and this boy had like a week to live. And so really doing that education and helping families understand that often the appetite isn't there. Please. She talked about how families really see food as love. I mean, if you think of us when we were little, something happened, your mom said, come on, have a cookie or have a glass of milk, or here's a candy, that'll make you feel better. You got to eat to get better, right? So that's a really hard lesson. Just recently, I was visiting a family who was taking a baby home that wasn't able to tolerate any nutrition and hydration. It was baby 8 in a large family. And so the family wanted the rest of the kids, all 7 of them, to be in the room while we were talking. And so I began to talk about this. And afterwards they said, do you have any questions? And the little 8-year-old put up his hand. I said, yeah. He said, last week I was sick with the flu and I didn't feel like eating at all. Is that what it's like? I said, yeah, that's exactly what it's like. So sometimes kids can get it much easier than adults. But it's very, very hard for families at the end of life, particularly when they've withdrawn medical nutrition and hydration, which is a whole other topic, to see the body kind of shutting down and not be able to care for the baby through nutrition and hydration. So really to be familiar with that. Again, drugs to think about. None of these will be new to you. I'm thinking steroids, Periactin, Megace. Constipation, this is our favorite topic in hospice, right? We all have that rule. We're good at that. So again, what's the norm? When I first went to pediatrics, our standard adult thing, if you haven't pooped in 3 days, we're in there with a good cure. Some kids don't poop that often. Their normal thing is, Johnny, he's always only pooped every 4 or 5 days. So let's not get worried if he gets. So again, we want to look at the causes. Lack of bowel regimen for drugs. You all know the one of the commandments of hospice, the hand that writes the opioid script without a bowel regimen is a hand that impacts that person, right? That disimpacts them. So we want to make sure that there is a bowel regimen. We want to look at pain and really try to prevent that. So again, let's look at non-pharmacal massage, and I won't go into that right now, but there are techniques that you can look at online about massage. Yoga, for our little babies, something as simple as doing bicycle with their legs often gets it going. In yoga, there is a pose called wind-releasing pose. I won't show you that pose right now, but look it up online. And certainly positioning. We know that when we get our older patients up and actually sit them on the commode, often that's enough. Same for kids. Pharmacology, technical term, mush and push is what we want to do when we're teaching students. They always remember this. So we really look at stool softeners. You'll see perhaps some of the ones we don't use as often in adults. I guess it varies across the country. Lactulose, Miralax are kind of our favorites. But certainly look at the natural things, prune juice, pear juice, those kind of things. And I know across the country it's different. Some people have those lovely Vaseline wafers that you freeze and people eat them. Other places they have milk of magnesia enemas, which sounds like something you put on oatmeal, but in some parts of the country they use it other ways. So do you have any other ideas?
It's the polyethylene glycol flakes.
No.
No?
Tell us
Miralax.
about it.
Yeah.
Oh, is that
It's
the same as
but
Miralax?
we use just different brand names, but we tend to use the PEG flakes quite a bit, and find it really effective, in particular for kids who with neurologic involvement in terms of nerve innervation. It seems to work quite well. The key thing is that it has to be regular use, so daily, and making sure that you don't go by the prescribed amount on the package, because it tends not to be enough.
Is that the same as Miralax, did someone say? It is the same. Okay, yeah, so yeah, we use that same thing, and we'll get through this. Warm grape juice and what? How about warm wine? Does that work? Mulled wine? Yeah. Sorbitol? Yeah, those little gummy bears sometimes work really well. One of our residents found out how well after she ate quite a few. Oh, yes, please. We do. For our inpatients. We haven't used it much outpatients, except unless it's at the very end of life and they've already started on that. Yes, we do. Thank you. And fatigue. Fatigue is a problem for adults and for children. Again, we want to look at the quality of life, do a good find out the cause. Is it because they're staying up till 2 o'clock at night and trying to get up to school till the next morning at 7? And what are the contributing factors? Do they have underlying pain? And we'll be looking at pain much more in depth this afternoon. And really looking at measurement. Again, the 0 to 10 scale is available, and there's other scales there too, but it's a difficult one. Often a non-drug thing is to get the PT to come in. We don't often use that in hospice, but to bring the physiotherapist, the OT, as Patrick mentioned, and to encourage as much physical activity as the child is able to and wants to do. Certainly counseling to deal with depression or difficulties, and memory prompts. Pharmacological, you'll see some of these. We do use Ritalin a bit for children, antidepressants, steroids, certainly looking at analgesia. So really our key thoughts, just to review them before we go to more questions, is evaluate and treat the underlying cause, and really just always use pharmacological and non-pharm. We tend to jump to the meds pretty quick, so looking at the non-pharm pieces. And
before we open up for questions, I just wanted to show some data with good assessment skills. Most institutions, this is ours, can show amazing 24-hour outcomes in pain and symptom management, but it all relies on great symptom assessment.
so for those of you whose employers are pressing for productivity and outcome measures, what a great measure.
Okay, so what symptoms didn't we talk about that's killing you? Secretions, okay. One of our fellows did a study a few years ago, and I hate her because she never published it, but when we did surveys on families, 60 days later, her data showed that it was the biggest memory the family left was secretions at the end of life, and how bothersome it was for them and their other family members. So it's a big deal. For children, I won't even pretend to do a guess. In our institute, there's not really good data. All three have been studied, and I say all three because there's not really a lot of drugs out there. Atropine, glycopyronate, scopolamine, should probably say it. Levsin, thank you. In one study that was done, I think it was in the 70s, don't hold me to it, looked at scopolamine, atropine, and it looked at Robinol, and what they really found was that the most effective seemed to be the atropine, but it also carried the most side effect burden. The scopolamine kind of sat in the middle, and the glycopyronate kind of had the least amount of side effects, but also seemed to be the least effective. So I think really what I've learned is the soonest you recognize that secretions are an issue, you need to treat immediately, because if you wait catching up is a nightmare. And so I'd say that the biggest thing is assessment if you're looking at secretions at the end of life. Now, if you're not talking about secretions at the end of life, it's a different conversation. But that's what you're talking about. Okay.
Right, so that education of the family is really important, and I've been able to ask some people at the end of life who have that gurgling, doesn't that bother you? And they'll say, what? You know, they've already half moved over there anyways. And so those kind of stories are really helpful to families. Educating the staff as well. Yeah, exactly. So with kids too, we would use the atropine. We do use sublingual atropine. We also use a sublingual Levsin. We often use Robenol because our kids have secretions. Many have a lot of secretions prior to the end of life. Robenol you need to be a little careful with because sometimes the secretions get too thick, and then it can cause more problems. The other thing we see in kids is urinary retention with some of the Levsin and that, so just be aware of some of these things, and certainly education on secretions at the end of life. Can I just, Maria, do you have any other?
I was just going to say there is some literature out there now. Albeit it's an N of 1, mostly case studies with regards to the atropine, and it's a little bit different in pediatrics. It seems like the atropine works better, and we don't have Robenol anymore on our pharmacy list. And the glycopyrrolate seems to be the one that causes the most side effects.
So I think it's different.
But I think it's just again, there's not great studies, but it's primarily N's of 1 because there isn't a lot out there, and most of the research is done on children with again neurodegenerative type diseases. One of the key things that we talk about is that education, and we find that those children who continue to be medically fed tend to have the most number of secretions. So part of that is that education about it's time to cut back and see how that makes a difference.
And often makes the biggest difference.
And I think the medically fed would be true in most adults too. If the feedings are continuing, you would have to think about that. Just before we take another question, caveat is also with secretions with adults is if this patient has a trach and you thick the secretions, you may be causing a new issue as well. So humidified air may be good. Obviously, things we didn't talk about, repositioning. I call them shovel masks, but face masks can sometimes, while they're giving a lot of humidity, they're often masking the sound if it's a problem for a family. So, think music, really got to think outside here.
So educating the family, and I think reminding them that it's not necessarily a lot of fluid, but just the way it's caught in the back of the throat is kind of like a trumpet, and it amplifies it. That last comment was just to say to the families, it's a bit like snoring, that doesn't bother the person, but it really bothers the person sleeping next to them.
I had a couple of comments for those people who may need help with extubations, which is very unique and this doesn't apply to a lot of people. But in terms of when you know that you're going to be doing a palliative extubation and you have the time to prepare, if you can put on a transderm scope patch, because it is slowly released and slowly absorbed but does last, I think it really does make a difference. But for the immediate death rattle, which is what patients' families remember more than anything else post-death, we use Robenol a lot, glycopyrrolate, and the best way that we have found anecdotally is that if you give 0.2 and give it for 3 doses 30 minutes apart, it seems to dry up the oral secretions extremely well so that there's not this rattling and need for suctioning, which is also quite noxious for patients, and then the maintenance of the transderm scope. So I think that helps a lot in terms of long-term for the patients who's extubated and going to live a few hours to a few days usually, that if you can maintain that, that's really a great deal of comfort to the family, who at that point is really who you're treating. So.
It's intractable hiccups and Thorazine is not working. What else could we use?
Sure, we have an algorithm. Actually, Thorazine is probably, using Thorazine is probably, at least based on the data, is probably the 5th line drug. Believe it or not, everyone tends to jump towards Thorazine. I think if you go non-pharmacologic, I think there was an interesting little study, and I can't tell you who it was. In England, where they found sugar on the tongue was probably more effective than any of the drugs that we offer. So maybe sugar, maybe mom was right. In terms of medications, there's some data for using baclofen. There's some data for using Haldol, which are so you don't have to use an injection, at least with the baclofen and the Haldol. There are other things, Thorazine's on the list, but in terms of data, it's kind of lower down on the list to use. Some hiccups you have to figure out if there's an etiology, like with cancer, there are ascites, so sometimes relieving the ascites actually helps hiccups because there's so much pressure on the phrenic nerve. There's actually a nerve block you can do to eliminate hiccups, believe it or not.
We're noticing it more with the esophageal cancer.
Yeah, esophageal and really any of the abdominal cancers, I think the incidence is going to be a lot higher than other disease processes. And so, but usually we pretty much start off with baclofen because it seems to be the most benign, but another place that needs some really good research. Great question.
I've tried the baclofen for years, and for some patients it works, but our PharmD is insistent that hiccups are a prodrome to nausea, so I've started using Compazine 5Q6, and it seems to work for a good deal.
There is some data for Compazine as well. Across the country, some people are just having a really hard time getting it, so it's a challenging drug to get.
Hi, I'm going to go back to the secretion management issue for a second. It's important to remember for patients who are still awake that are dealing with secretions that Robenol or glycopyrrolate will not cross the blood-brain barrier. So that's actually my preference of choice versus scopolamine. Going back to the importance of normalizing it for your patients or your family is even with best approach, less than 30% of patients will have success with minimizing secretions with medications.
It's a common problem.
It's a common problem, yes. Relief of a headache with someone who has brain metastases, is on high-dose steroids, has received radiation therapy, opiates, and nothing is working.
Rotate the opioids.
Yeah, boy, that is kind of the patient no one wants to see.
Did you try rotating the opioids? Try a different opioid like methadone?
Okay, so opiate rotation is an idea. So I think that's a good idea. If it's due to raised intracranial pressure, okay, I'm thinking outside the box here. So would a prophylactic LP decrease the pressure intracranially? In the old days it was done. It kind of went away, but neurosurgeons will tell you that with bleeds, they would do the same thing. That in theory, that would be something I'd think about. And I would be talking to these people. I'd be talking to neurosurgery and I'd be talking to neurology. I work on a pain service, and when we get headache consults, my first call's to neurology because everyone wants to think about Furoset, and you say that to a neurologist and they cringe, say, no, don't do that. And so really trying to think outside the box. Headaches are really challenging. And you've got an etiology, but a good headache assessment takes a lot of work because, could it be history of migraines, non-migraines? Could it be stress? Could it be frontal lobe? There are so many kinds of headaches, and frankly, the treatments can be very different. Early headaches, there's some data that the neurologist said at a conference I was at, and I'd love to read it, was 2 liters of oxygen in a quiet room was more effective than any other medication that they initiated. So I would be bringing in people.
And methadone, yeah.
Yeah, part of an opioid rotation.
One of the things to remember is don't forget the normal things like Tylenol or ibuprofen. Sometimes those can be really effective. But also, again, looking outside the box for complementary therapies for some of our kids. Healing touch or those energy work really well. Mm-hmm. And massage, right. Acupressure, acupuncture.
We just treated a 53-year-old male with leptomeningeal spread, and he had a throbbing headache for about 3 months before he came in, and they used the high-dose steroids, but we also added on board Elavil, and was Elavil 10 and naproxen 500 BID, and it resolved it.
Well, there's some data using tricyclics to help prevent and treat certain kind of headaches. So sure, absolutely. I think this is by time our last question, so.
Hi, I'm wondering if we could go back to terminal agitation for a minute and ask for any comments about that in the veteran population.
Terminal agitation in the veteran population, and really what I think you're asking is, do they have PTSD, post-traumatic stress disorder? And I think that is something that, in the veteran population and also the non-veteran population, but clearly you have to think about, are they reliving things that, in illness, people have had trauma, post-traumatic stress disorders. In severe illness, they may reoccur, and they may reoccur dramatically. Often palliative care may be diagnosing it for the first time, and the guy's been a veteran for forever. So I think you really have to go back to understand what their life was like, what caused them trauma. Are they willing to talk about it? If they had exposure to Agent Orange, if they were if they were ever a prisoner, higher incidence in women, so you think about rape. So really, post-traumatic stress disorder is a huge thing, and it really requires someone who can do a really careful assessment and bring out things that may be bothering them. It may be a family interview as well. It really is bringing in the professionals. This is a big deal. Long-term treatment is SSRIs and counseling and end-stage disease. They aren't going to have the opportunity to work, and so that you really need to bring in a lot, and more data is coming out. This is something that I think everyone's getting a lot more awareness of, but treatment really needs a lot more time. So I think when you think agitation, that would be on the list of things to consider. Could it be post-traumatic stress disorder? And I thank you for bringing that up. That's a big deal.
And if we can remember, it's not just the veterans, but a lot of our immigrants have had very traumatic experiences prior to coming here, and even our teenagers have had pretty traumatic experiences. So there's a list of references, and thank you very much.